Byline Audio.
Is your cold making it hard for you to get to sleep and leading to a bad morning? Switch to Mucinex Night Shift for fast, powerful nighttime multi-symptom cold and flu relief. Mucinex Night Shift fights your worst nighttime symptoms to help you get to sleep and wake up ready to go. Mucinex Night Shift. It's comeback season. Use as directed.
Ryan Reynolds here for, I guess, my 100th Mint commercial. No, don't. I mean, honestly, when I started this, I thought I only have to do like 4 of these. I mean, it's unlimited premium wireless for $15 a month. How are there still people paying 2 or 3 times that much? I'm sorry, I shouldn't be victim blaming here. Give it a try at mintmobile.com/save. Whenever you're ready.
$45 upfront payment equivalent to $15 per month. New customers on first 3-month plan only. Taxes and fees extra. Speed slower above 40 gigabytes. See details.
Hi there and welcome to the Byline podcast. My name is Adrian Goldberg and this time the ongoing row about physician associates. These are healthcare professionals that might see patients in hospitals or at a GP surgery, but who aren't qualified doctors. We're going to share with you the story of Emily Chesterton, a patient who sadly died after being misdiagnosed by a PA, and asking whether we need to rethink their role. The Academy of Medical Royal Colleges has said there should be a review into the safety and usefulness of physician associates and anaesthesia associates amid fears that they are sometimes performing tasks outside their capabilities. PAs do all have degrees, usually in the health or life sciences field, and they have a further 2 years postgrad training. But, as I say, they are not fully qualified medics and should always work under the supervision of doctors. We heard a few months ago from Dr. Matt Neal. Matt is co-chair of the Doctors Association, a lobbying organisation, who outlined his concerns.
Our first and foremost concern, as always, has to be about patient safety. So as you touched upon there in the introduction, I mean, the level of education and training that a physician associate or anaesthesia associate undergoes is no way near any level of medical training. We're talking about a 2-year postgraduate degree, but the quality of the undergraduate degree is very variable. You can't necessarily carry that information over. We know that these individuals primarily work with undifferentiated patients. By that, I mean patients who could come in with absolutely any problem whatsoever, to a general practice or to an A&E department. That's the vast majority of patients. The issue with that is that you don't know what you don't know. That's something that we're really having into at medical school. You don't step beyond your competence. You simply do what you can. If you don't understand, you raise it to a senior and all this sort of stuff. We've seen from national evidence that we've collected, really, that process seems to be lacking. That seems to be what the main issue is. From all the concerns we've had raised from doctors nationally in terms of the episodes of bad practice or potentially dodgy practice, it's do they know what they don't know? And we are really concerned about that. Primarily, I mean, we have to be fair to them. Most of them come in with some sort of science degree of some sort. I mean, for example, I did a graduate entry medical degree. So I did it in 4 years, right, which was a tough word. That was a slog. I don't think you could do it any shorter, really. And my previous degree was a science degree. It was a biomedical science degree. I still find the graduate entry medical degree incredibly challenging despite my scientific background. So we have to bear that in mind, really. The difference in learning is just stark. And we've heard that from previous PAs themselves who've gone to study medicine, that actually it's like night and day, black and white, really. There's no comparison between the two courses.
At the same time, though, when physician associates are on the ward or are in GP surgeries, they have to be under the control of a doctor, don't they? Under the control of a qualified doctor. Now, that may be direct control, that may be indirect control, but they're not working entirely without supervision.
It's tricky, really. I think it depends where you're looking at these PAs particularly. In general practice, they have to be supervised, as you say, indirectly or directly by a consultant. A consultant in general practice is a fully qualified GP. Now, GPs, as you know, are incredibly stretched. If you look at the training that a GP trainee would get, there's dedicated supervision time within that rota. It's quite costly in terms of the time for a GP to train a GP trainee. What we found with PAs generally is that they have a very short period or a short window where they are intensely supervised, in the first 12, 18 months perhaps after graduation. But after that, it drops off rapidly. And we're seeing stories of people having supervision, once a week or once a month, discussing cases with their supervisor. There's no way that can be safe. There's simply not a way. And whether it's just because the acuity of patients and the severity that they come in with is slightly lower in general practice, perhaps you're getting away with it. That's one concern. In hospital, it's a little bit different because, yes, it has to be a consultant overseeing you. So someone who's at least 10, 12 years postgraduate and, the top of their game, really. What we found is really that the trusts are basically acting as a Wild West, really, in this situation because of this lack of regulation and this lack of scope of practice, what we call for PAs. Essentially, they're just doing whatever the employer wants them to do. And there seems to be very little fight back on that. So we've heard some absurd stories. PAs are involved in neurosurgery without much neuroanatomy training and stuff in their previous degrees, or people doing independent bladder surgery, essentially mini surgeries alone. There's loads of worrying stories, and there are literally hundreds of these. So you can see why we are worried about patients, really, in this context.
So that's Dr. Matt Neal from the Doctors Association, welcoming now Marion Chesterton from Greater Manchester. She's the mum of Emily Chesterton. Marion, welcome to the Byline podcast. You and I have spoken on the phone about Emily's story, and I was so moved by what you told me. I'd just invite you now to share that with our listeners here.
Emily was 30. She just turned 30, actually, on the 14th of October. She lived in London, in Crouch End, and she was at home for her birthday and other family events as well. She did say that she had a bit of a soreness in her leg and her calf. And I said, well, get it checked out. She went back to London and she phoned her surgery in Crouch End and talked to a receptionist who said, well, it sounds as if it's, sort of muscular. Take some paracetamol. If it doesn't get better, make an appointment, which she did for the 31st of October, where she saw a PA. But Emily thought and really believed that she'd seen a doctor. She was told by the PA it was probably a sprain, muscular. She'd had COVID in the August, so she was thinking about long COVID. It didn't get any better, so she made an appointment again for the 7th of November. By this time, she was very breathless. She was coughing. She found it difficult to walk. She was very anxious, obviously, because she was feeling so ill. She was living with her partner at the time, Keone, and she was still working, believe it or not. He was walking with her to work because she felt it very difficult to walk to work and back. I'd had an operation on her birthday and felt that there was something wrong. She wasn't telling me that there was something wrong, actually. And I think looking back, she was trying to protect me, and she knew that I was recovering from a craniotomy. Well, we went down and saw her, and I was shocked. She'd just come out of the doctor's surgery, not had a long time in there. She'd about 3-4 minutes. She hadn't been examined properly. The doctor said she'd got long COVID, sprain, anxiety, same thing. Wasn't worried, wasn't anything serious in her opinion. And next day, she'd arranged for a chest x-ray to be done at a hospital. So I was in a bit of a quandary, actually, Adrian, because she looked ill. She looked so ill. And yet we'd just been told that the doctor who'd seen her twice didn't think it was anything serious. She was going to the hospital the next day.
And just to be clear here, Marion, when you refer to the doctor, this was somebody at her GP surgery who she and you believed was a fully qualified doctor, but was in fact a physician associate.
Yes, we didn't know it wasn't a doctor. That night, we picked them up and took them to a restaurant near where we were staying. She had been prescribed as well a drug, propranolol, which is a beta blocker for anxiety. And she was told to take one when she next felt anxious, which she did at the meal. She said, I'm starting to feel really breathless again, and I'm getting a little bit worried and anxious. And Keone had brought out her prescription, and we encouraged her to take a tablet. After which she said she felt very weird and collapsed. The next couple of hours were traumatic, to say the least, phoning for ambulances and waiting for an ambulance. And I sat with her and kept telling her everything was going to be okay. She was obviously very ill. The ambulance came, took her, and she died in the ambulance. She had a cardiac arrest. We followed in the car. When we got to the hospital, we were told to go to the family room. So we knew that something was afoot. When we got outside, the paramedic told me that she'd had a cardiac arrest in the ambulance, at which point I collapsed onto a lamppost. It was a lamppost behind me, I remember. We went into the family room, were told that they were doing all they could, but because she'd taken propranolol, that had stopped them treating her properly, and they'd had to give her an antidote to that first before they could treat her.
So the anxiety drug, which she had been encouraged to take by the physician associate, actually harmed her, made it more difficult to save her life in that situation.
Well, it stops blood getting to your heart because she had a pulmonary embolism starting a calf as a DVT. So it made the situation even worse. It was the worst thing she could possibly have been prescribed. And we encouraged her to take it. And I'll live with that guilt for the rest of my life.
But you were only doing as a mum what you thought was for the best based on the advice of what you thought was a doctor.
Of course, but, you don't think like that, Adrian. Looking back, it still gets to me now.
It's such a sad story, Marion. It really is.
I'll get myself together.
That's all right.
We were told by the doctor that they were trying all the best they could, and I just said, please try your best. They consulted a senior cardiologist who said that basically there's nothing that could be done. And we were told to say our goodbyes. So it went from taking down birthday presents to saying our goodbyes, which, we just couldn't believe it. It was just incredible. So we then had to drive with Peony, a partner. We all went back to Crouch End. I don't know how we got through it. We had to drive back to Manchester just non-stop the next day and tell her sister and her grandma. And it wasn't until the inquest 5 months later that we found out it wasn't a doctor. It was a PA, and I didn't even know what a PA was. I had to sit down and, get my head round it, really. It was just the whole process seemed to start again, the grief, because we'd never heard of what this person did. And then when we found out that she'd only been in the surgery for 2 months, totally unsupervised, both times, she wasn't supposed to prescribe. It had got through. The doctor was so busy, she just signed off all the prescriptions that Monday afternoon. She wasn't even supposed to refer her to hospital for an x-ray. So all in all, if we'd known, seeing her so ill on that day, hadn't actually been a doctor that had seen her, then of course we would have done something further. We would have taken her to A&E. And at the inquest, the coroner's decision was that if on either of the occasions that she'd attended the GP surgery, she had been sent to A&E, she would have lived. So you can imagine the absolute grief and upset and torture we've been through as a family ever since.
Absolutely. And when you first discovered that the misdiagnosis had been made not by a doctor, but by a physician associate, how did you get your head around that? What did you make of that?
It was really difficult, I must admit. I wouldn't describe myself as an angry person. I think I'm a very liberal, kind, generous person. And I was actually up to that point feeling quite sympathetic towards the other people involved in all of this. But I must admit, I did get very angry. And it did affect me, my mood, my person, it affected me. And I didn't like the way that I was feeling. Husband and I, Brendan, we were having therapy at this time, and I think that did us a lot of good. And we did talk to our therapist about all of this, and it was the middle of our therapy that all this seemed to happen. I was talking to a friend, a good friend I'd worked with in the past, and a really good friend from church, and they both said to me, well, you've got to use this anger. It's righteous anger. It's natural to feel that way, and you've got to use it and do some good. So that's when I started to actually physically do something. So I wrote to my local MP, Barbara Keeley, in Worsley and Eccles, and the ball started rolling from there. She got in touch with the Speaker at the House of Commons, and she managed to get us a debate, and a German debate. We travelled to London to see that. And she was fantastic, by the way, our MP, she really was. Following that, a German debate, We were approached by several news agencies and we started to give interviews, and we were invited to the BMA conference in 2023 and we spoke there. Then we were asked by the AU, the Anaesthetists United, if we would like to join them in their cause. We actually met the CEO of the GMC as well. I'd written to him. It's called Charlie Massey, and we had a few letters back and forth, and eventually he asked me if I wanted to meet him. So we did. We went in Manchester to the headquarters there and we met him and talked to him, and we were quite reassured actually after meeting him, because regulation starts on December 13th, as you're probably aware, of PAs and AAs. I had lots of questions to ask, and I wanted to be reassured that there would be no more cases like this, no more Emily's. I should have said that to him and he repeated it back to me, no more Emily's. So we came away quite reassured, but then we discovered that the GMC isn't going to regulate as I thought, as I believed. For us, big questions are around supervision, as the PA was unsupervised on both occasions. Supervision for me means one-to-one. I mean, for other people, it might mean that you're in the next room or at the end of a corridor, the end of a phone, in a different building even. It's difficult to define supervision, and that would still be a very vague concept. And I don't think the GMC are going to settle that properly. Also, we feel that a PA or an AA should introduce themselves by saying, I am not a doctor, I am not an anaesthetist. And that isn't happening at the moment. Doctors are being replaced by PAs in hospitals. It's been proven. I've been involved with a campaign on the Mail on Sunday with a journalist called Ethan Ennells, and they've found out through a Public Information Act that in Blackpool, for example, PAs were running a maternity hospital. It is going on, and people have died since, Emily, because PAs haven't been supervised sufficiently.
You mentioned the role of regulation from the General Medical Council. So ultimately, PAs will have to be registered with the GMC.
They're talking about setting standards. When I talked to the CEO, he agreed with everything I said. For me, limits have got to be set, specific limits. For example, at the BMA conference, we talked about a scope document that had a traffic light system, which we thought was great. And if that had been in place when Emily needed help, she would have been alive, because it states absolutely spot on, red light, they must not do this. Amber light, only with supervision can they do this. Green light, yes, they can do this. They need to know exactly what they can and cannot do. And if it's simply passed down to employers to make up their rules, that's what's happening now. It's still going to be the Wild West, in my opinion, people making up their own rules as they go along.
Because the GMC will have a role in potentially disciplining a PA if something goes wrong, but to prevent something going wrong in the first place. That's why the GMC's involvement, although welcome, it's not really sufficient, is it? Because the NHS being hard pressed and GP surgeries or hospital wards with PAs on, the GMC isn't there to say you can't do this and you can't do that. Earlier this year, I know the British Medical Association said that PA should be banned from diagnosing patients. I mentioned that in recent days, the Academy of Medical Royal Colleges said there should be a complete review into the safety and usefulness of physician associates. Do you think that they have a role at all in the NHS?
Initially, if you'd asked me that when I first started campaigning, I'd have probably said no. For me, I couldn't get my head around why we needed somebody in an office doing a job, a physician associate, if they needed somebody looking over the shoulder. What was the point? Why don't you just get a doctor? And there are doctors unemployed out there. There are, especially in London. So what was the point of it? I couldn't get my head around that. But I know there are good PAs out there, and I'm not one of these people who will say they're all rubbish. That can't be true. I know that there are well-meaning, good people out there, but it's true what Matt before said. You only know what you know. You can only do what you know. And their training isn't the same as a GP's. GPs spend 10 years. I think limits, if they know exactly what they can and cannot do, that's going to help the PA. It's going to put their mind at rest. As I said to Mr. Massey in the meeting, the CEO of the GMC, if my child came to me and said, Mum, I want to be a PA, I'd say, oh, no, you're not. It's too much responsibility. Can you imagine going through, thinking, oh, my goodness me, I've diagnosed this and it was this and this patient's died. Can you imagine the responsibility on that young person's shoulders? It's just not fair on them. It's not fair on them, leaving them on their own. It's not fair on anyone at the moment. Patient safety is paramount. Everyone agrees on that, don't they? But we also need safety for doctors, safety for PAs. The whole thing, it's got to be absolutely tight, consistent, robust. It's got to be sorted out properly. They've got a real opportunity here. And I'm fearful that this opportunity will be wasted. And what's happening now will carry on. And more people will die. And more PAs will suffer because of that. And more doctors as well. It's not, in any sense of the word, ideal.
Marion Chesterton, the mum of Emily Chesterton, my thanks to her. Now, we did contact the NHS for a response to Emily's story and for the question of PAs in general. And an NHS spokesperson said the NHS has always been clear about the role medical associates play in supporting clinical teams to provide high quality care for patients. They are not replacements for doctors, but support teams with specific tasks they are trained to do under supervision. We know that the confidence of the public and the medical community is absolutely essential as we develop an NHS workforce that is fit for the future, which is why the NHS has issued updated guidance on the appropriate deployment of these roles. And we will continue to work together with government and medical and patient groups to provide clarity on these roles for patients and the public ahead of the GMC regulation coming into effect at the end of the year. Before we go, just a reminder that the Byline podcast is supported by subscriptions to the Byline Times. That's our wonderful monthly news magazine, and it contains content that you can't read anywhere else and some brilliant articles in there. I do recommend it. So head over to bylinetimes.com, and if you can, please take out a subscription to the Byline Times. This episode of the Byline podcast has been produced in Birmingham by me and Harvey White. Thank you very much indeed for listening. We'll see you again soon. Cheers now. Bye-bye.
Byline.